Hi everyone, my name is Paul Jones. I'm Chief Digital Information Officer. We've got a couple of things that we're covering today at Report Out. The first is one of my teams, which Guy Dickey's going to lead on that for us. That's around the project delivery lifecycle. So Guy, do you want to kick off with that?
Yes, certainly. Thanks, Paul. Good afternoon, everybody. Guy Dickey, Associate Director for Digital in DIT. Thank you for having us here today. Project Delivery Lifecycle, PDLC. So about a year ago, it became apparent that there wasn't a clear way or something it lacked clarity on how to commission DIT to take on technology-enabled transformation projects or change projects. It also became clear that we lacked a process within DIT to deliver well-governed, well-informed and transparent projects as well. So that's where PDLC came from. That's our sort of solution to that situation. And so what I'd like to talk about today is what it was like before PDLC came along, our project delivery lifecycle methodology, whereby we're commissioned to deliver projects, and then how we actually execute those projects. There'll be an overview of what PDLC looks like, the various stages of project to go through, some reflections on what's working well, some of the key challenges we face, some in-flight developments we're making as we continue to enhance the process, and then there should be time for Q&A at the end. So PDLC as a concept, we started work on it around about this time last year and is launched in August and has become the sort of de facto way that DIT is commissioned to execute IT change projects, how we actually execute those projects themselves. I'm pleased to say we've been approached by colleagues outside DIT within the Trust who's asked if they can use PDLC, and we're delighted that it's being adopted elsewhere. This is really the evidence, if you like, that backed up our theory that things weren't quite as good as they could be. We engaged with CSUs and the corporate ops team just to get their feedback on how they saw DIT in terms of doing change projects. Going from the top left, blue box to begin with, when a project was commissioned, it's quite often unclear on the impact on other parts of DIT beyond the project team. We have a team of maybe 10 project managers. So other parts of DIT, such as service management and tech services, the impact on them is not fully considered. And that often led to projects being blocked or sort of being stalled, should we say. It was unclear on process to commission DIT to undertake work and projects. There's a misalignment between the size of the portfolio and the available resources. So around about April, May last year, we did an audit on the number of projects on the books, and there's actually 87 that we unearthed, but there's fewer than 10 project managers to do that work. So a bit of a challenge. There's also limited access to timely, transparent and consistent reporting. So if I'd asked DIT to do a project, it was really hard for me to find out the status of my project, how is it going, when is go live going to come, all that sort of stuff, how my costs are tracking. There's also this misalignment, the CSU's expectations of DIT's ability to meet those expectations, partly down to comms, partly due to a lack of transparency, partly due to a lack of process. We also found that budget and total cost of ownership was not always fully understood. There's an expectation that DIT is like an infinite free resource, they just pick up and pay for everything. But no, like every other CSU in the Trust, we have a budget and a scope. So anything beyond that funding would need to be found. And also, it's not just the cost of maybe some software licenses. There's things like the cost of people to do the work, any specialists that need to be brought in, any additional storage or networking or cabling, all that sort of stuff was frequently not understood or not taken into account. And finally, governance and information governance arrangements were not always clear. When we did that audit and discovered there's in theory 87 projects in flight, there's a significant chunk of them where there wasn't an SRO or in fact anybody who's owning that project outside of DIT. So who's actually commissioned us to do the work? The sort of acid test was who would be upset if we decided not to do this. Equally, arrangements around IG were often patchy. So I'll now hand on to Andy Cochran, who's going to take us through our response to these challenges.
Good afternoon, everyone. Andy Cochran, Project Manager working in the Project and Programmes team, supporting Tracy, Rob and the Project Delivery Office. As Guy alluded to, we created something known as a Project Delivery Lifecycle, which without seeing a few of the slides, people be thinking, what does that mean? So it started life with the PM community, driven by some of the catalysts and some of the things that weren't quite right, as Guy just alluded to. Obviously, internal stakeholders, CCIOs in particular, and obviously working with PwC to get sort of an external perspective on what we're doing. Simple framework, a number of stages. It's all about delivering consistently and keyword transparently, so people can see what's going on with their project, why it's not going well, etc. And it shows you, from the start, from the idea through to a project closure. These will be covered later, but ensures sort of a standard single entry point into DIT. That's the first two stages, expression of interest, request for work. That's where we get to review, assess, challenge the work that we've been asked to do, but that's important. And then on the basis of, yes, it's still the right thing to do for the Trust, and there's approvals and there's funding, etc., we move forward into mobilising the project itself. But by having this and socialising this, it helps stakeholders across the Trust understand just what's involved in delivering a project. The things we have to go through, the governance stages. And I say it's not just project governance, but the things like information governance, procurement, clinical safety, technical services, making sure that the solutions that are being delivered for purpose, being tested, they're ready to be going to service, ready to be handed over, those sort of things. So it helps people understand. There's a couple of documents in here that help stakeholder matrices, for example, helps stakeholders understand their obligations and accountabilities, and it actually prevents shortcutting of process, because there is obviously in the past evidence of projects going from an idea straight into delivery, missing out lots of key stages around design, test, procurement, the right supplier. And there's a number of things we do, not only the way we go about it, a number of key stage gates, which are going to be covered shortly. So you can't probably see on here, but the red arrows, there's a sort of 3 key governance forums that again are covered later. One is the project alignment group. That is the forum at the beginning of the process, make sure this is the right thing to do, DIT can do it. And then when it moves into delivery, we have something known as a project control board. And that is, again, a senior management forum where to make sure projects are ready to go from one stage to another. They've got the appropriate sign-offs, the things that have been done that are expected to be done, like a signed-off mandate, funding in place, designs done, all those sorts of things as you move on. We found that to be very successful. So I think part of that process is to be quite tough on projects. Are you doing the right thing still? Are your benefits still stacking up? And having quite tough conversations to say maybe, things need to change. And then going back to reporting that Guy alluded to, we have very detailed reporting done across all the projects, where project managers obviously report, can learn from each other, get guidance, but more importantly, that information goes wide across the trust. And it's probably a good time to hand over to Rob next.
Thank you, Andy. Hello, my name is Rob Child. I'm a Programme Manager in DIT, but I also head up the newly formed Project Delivery Office. So me and my colleague Alex are going to tell you a little bit about what's working well in this newly formed process. So if we start with the front door, as we call it, the expression of interest. So we started in July 2020, and we've had so far 155 EOIs that have come in to DIT, so people are finding the front door. So we've had 24 areas have requested an EOI, so that's every CSU have put in at least 2. Plus we've had both regional and national requests, so things like regional maternity, the LIMS and scan for safety as well. So they're following our process. What happens there? So it feels like we've got good engagement. I know many people on the call have been through that process. So starting with that EOI, then we turn that into a request for work, which tells us a little bit more about what the ask of DIT, so we can start to formulate what this would look like as a project. And going back to what Guy's sort of saying, we can look at cost, effort, etc. Because like we say, DIT does have a finite amount of resource. So looking about how we plan that resource and what is the priority. So what happens is we'll have a discovery meeting with the requester, and then it will come to the project alignment group, which we have our senior leads of each discipline within DIT, so we can start to understand what this means, and we get to raise sort of flags and questions and all those really interesting takes on what does this really mean. And then on from that, then we start to initiate, and that's where it comes into sort of the third gate in the process, really. So it's initiated and it follows that process to be able to provide the requester and the team with sort of that transparency, etc. Again, every CSU has put in at least 2 requests, but the interesting thing for me is obviously the top bar there, you can see informatics is the top requester. So that shows we are following our own processes and governance. So in Leeds way values style, it is very, very fair. If I just hand over to Alex now.
Yeah, so my name's Alex. I'm a delivery analyst in the projects and programmes team. Another thing that's working well and adds value to the PDLC is our project portfolio. So this offers a single view of the current and upcoming demand. You can see a clear prioritised view of the 68 live and pending projects and initiatives we have. You can also see a number of the projects that we have closed and archived. We do share the portfolio on a weekly basis. This offers transparency and awareness to quite a wide distribution list. Our corporate ops colleagues are included in that distribution list as well. Our plan in the future is to share this via the intranet, so for wider trust viewing. Some examples of the information we capture are basic data such as a project name, which project manager is assigned, expected start and end dates, to a bit more detailed information such as when the target attendance dates are for the project control board, and the artifact checklist. So that information specifically relates to one of our governance meetings, which is the project control board. That meeting is chaired by our senior leadership and is assurance based. So this ensures that projects are formally tracked through the PDLC, and it just prevents any sort of essential activity being missed, where project managers will bring their approved documentation and plan for progressing and seek approval to move on into the next stage gate. So visibility, transparency, awareness are all drivers behind PDLC. We have quite a well-established project review board now, which is a weekly meeting that ensures sight across all projects that are currently in delivery. Another meeting that's chaired by senior leadership. This is where the project managers will offer a verbal update relating to key achievements and the focus for the previous and upcoming weeks. They'll also share their plan and highlight any key issues and risks. Any escalations can be shared in this group as well, which sort of helps capture any issues and make sure that support is offered from quite early on. It is a great opportunity for the PMs to share experiences and learn from each other as they move through this new PDLC. Everyone's in different stage gates. So the images on the slide are just examples of what we share in the meeting. You've got the high level plans which are shared with each project report. The summary pages outline timeframes of the project, and they also highlight any delivered, proposed, confirmed go live dates by way of the little triangles. And again, this is something that we would look to share on the intranet going forward. Thank you.
So hello, my name is Tracy Whitfield. I'm head of EHR delivery. So part of the work that we've been trying to do with PDLC, as we say, is uncovered there's a massive amount of work to be done within DIT, and part of the process that we're obviously having to manage is how do we prioritise that work in order to make sure that the most important pieces of work to the trust are delivered rather than just what we might want to do first. So we have added a prioritisation decision support tool to our process, which is effectively a scoring mechanism that allows us to take each request that comes in and measure them against a single set of questions so that every project request is measured in the same way, and therefore it allows us to bring a little bit of subjectivity to a quite complex issue. And effectively, this tool gives us scores in 3 separate areas. So it allows us to measure the impact of a project, the complexity of delivering it, and also the amount of resource that's going to be required to deliver that project. And the output of this questionnaire then forms a separate prioritisation process. So we now have a prioritisation group where we take these scores and what we know about the request for work and all the involvement that Rob and Alex have described, working with the requesters about their project. And we take it to a group that involves both our clinical colleagues, corporate colleagues, and obviously DIT's voice. So we're making sure that we've got a wide consultation to actually look at what is the correct order of delivering projects. So each new request that comes in is measured against a stack of this is what we're currently delivering. These are the projects we believe are coming up next. So a new request may come in at the bottom, middle or top of that list, but it's measured against everything else that's currently in the stack. I think it's back to you, Rob.
Okay, so just want to talk a bit about how we're developing PDLC. Like we've described, we have a finite amount of resource, so we're getting better, and we've got a number of tools now to help us forecast the supply and demand, so projects coming in, and we're measuring it against what we have to do, sort of BAU, as I would like to say, keeping the lights on. So we have to sort of balance this up and see, how we can deliver projects alongside those things to keep clinical services running. We also need to look a little bit closer about how we deliver regional projects and programs, because they are slightly different. So things like genomics and LIMS, so they have their own governance around them, but also obviously there's an impact to the trust and to DIT. So how do we make sure that that is managed and is transparent to make sure they are delivered on time and on budget? And also what we're looking to do, or what we do is we have a PM sort of community, really. So we've had a number of PM networks, and I'm sure some people on the call have been part of those network events. Really, we have a number of guest speakers come along and share their experiences, etc., of their sort of world and how we can improve sort of projects. So that's a really great thing. So we're building up our capability. So yeah, they're the sort of 3 things that we're really focusing on. So I think we're into Q&A now.
Thanks for that, Rob. That's Rob, Guy, Alex, Tracy, Andy. I didn't realise I had quite a cast of thousands presenting today, but thank you for presenting that. Yeah, I mean, this is something that's very, very close to me. I kind of felt when I joined the trust about 18 months ago, there's about 400 staff in the digital team. and that meant there was about 800 ways you could request work, because you could phone us all up and you could text us all. This kind of just creating this single view of how you go about requesting programs and projects, I think is really significant, and you can see the grip that the team have got now on this whole space compared to what was a slightly sort of wildfire situations at times in the past. So hopefully that means that we can deliver more effectively to the trust and to all of you. So and thanks, Liz, for your comments. So Jo?
Yeah, hi. It is really impressive. Yeah, thank you. It's really good to see how it works as a framework. I'm just wondering then about the different projects, because I'm feeling, in the CSU, don't really know where our projects are with what we've requested, and that feedback to the CSU. And also where you're doing the scoring system about the impact, which I think is right and I think it is fair. But when your things that would make a massive difference to your CSU, but maybe not so much for the whole trust-wide, does that mean that you'll always get lower down priority in what needs to be done and delivered?
So I think that's a fair question, Jo. And before I just hand over to the team, I think that scoring in that process is still quite new. So it's absolutely open to some change and some challenge. So recently we brought a medical director into that process to make sure that quality and risk are appropriately assessed. And so I guess Guy, are you the best person to answer that, but I think just to say we're still working on some of that.
Certainly. I mean, it's been probably the hardest part of PDLC so far, the prioritisation decision support tool, as we call it, trying to bring some objectivity towards a very subjective space. And we're actually presenting to Corporate Ops on the 11th of May just to get the process ratified. It is, there's so many competing factors in deciding how we, what the batting order is, and which project goes next when a project's completed. But yeah, we're very open to taking feedback on that, and I'm looking forward to that session on the 11th with Corporate Ops colleagues. I mean, it's a much debated subject, and it's taken a lot more effort to get to this point than I'd anticipated, actually, Jo. But yeah, it is hard.
Because I can imagine it is really hard, but I feel some of the things that would have, might have a greater weight on paper, but that are just really stifling us in the CSU by not progressing. So any help with that would be very welcome. Thank you.
And I think we need to try and bring that out in the explanations that go into that meeting, Jo. So, we're still working that through. Anthony?
Hi, hello everybody. It's Anthony Cronshaw here. I'm patient partner. Can I just say that was massively reassuring from a patient point of view. As we travel further and further into the information flow epoch, leaving behind the global information epoch, which has governed all our activity for 500 years. It's really important that we have structure in what we do, in order that the purpose of particular initiatives are judged against trust values. So I really loved it when Rob linked the work that you've been doing back to the trust value of fairness. I mean, it goes without saying that all this relates enormously to the area of accountability as well. But it's really very reassuring from a patient point of view that the trust has got this structure which is going to allow it to fundamentally ask the question, not can we do it, but should we do it?
Thank you for that. Really appreciate that. And on that kind of very positive note, could we move on to the patient experience team? Christina, I think you're leading on this one.
Hi, I'm Paul. Thank you very much indeed. So hello, everybody. My name is Christina Kozłowska, and I'm the head of patient experience for their trust. And I'm really pleased to be able to share today that we have commenced cohort 2 of the Complaints Improvement Programme with 3 new CSUs who are neuro, cardio, respiratory and women's. To do this, we held a workshop on the 19th of April to launch the programme. And this is going to work slightly differently to the first programme that we've reported out through Report Out previously, because it is a scale up and spread programme, which means that we are taking the learning that's achieved from cohort 1 and sharing it with the cohort 2 participants and challenging them to introduce this into their ways of working. In addition to that, each CSU taking part this time has been asked to test any other activities that they feel might be beneficial for their CSUs based on the waste that they've specifically identified relates to their CSU. So a bit of a different approach to what we've shared here before, but an exciting one, and we're really looking forward to seeing how that plays out. So today it's not a day actually today about sharing lots of information about how we've seen improvement in data, but it is about sharing a day zero baseline position. And I'm going to be inviting each CSU shortly to share the work that they're intending to progress to meet the objectives of the programme. But just a quick note for those of you who might be wondering about how the CSUs in cohort 1 might be continuing to be supported from an improvement point perspective. And we have introduced regular meetings with each of those CSUs going forward so that we can continue to have those important conversations about how improvement can be achieved and to keep a focus on complaints. And also, I think, crucially, so that we can share the learning that arises from this new cohort with the ones that have already been through it. So we're hoping to scale and spread in 2 different ways going forward. Next slide, please. And the next one, please. Okay, so this is just an update about the baseline position that CSUs are currently reporting at the start of the programme. So this is the standard TPR that you've seen before. You'll see that all the CSUs are starting from a different starting point, as you would expect as they go into this programme. And we very much ask them each to consider how they can improve their baseline position as they go forward. So, for instance, in terms of lead time, we would ask them to challenge themselves to see how they can achieve a 50% improvement. And just to explain the metrics that we will be monitoring going forward again for everyone's information, the lead time relates to the number of hours a complaint sits within a CSU from the time it is received by them to the point that actually it leaves the organisation. We monitor that for reduction, and then the other really key indicator here, just to help you understand, is the one around quality defects. So we are always putting a focus in these programmes on trying to improve the quality of experience that the complainants have, and part of that is the way in which they interact with the final response letter that they receive, and where those responses are reopened for reasons that we could have influenced, then clearly that is a negative that we want to reduce in our system, and hence we monitor the number of times that that occurs for each of the CSUs, and will be one of the indicators we're looking at going forward in terms of improving our quality. I am now going to pass you on to our individual CSUs, who are represented by Lindsay Mutavivari, Sarah Miller and Eleanor Gleed, and they'll take you through the individual work that they're considering doing. And thank you very much. Next slide, please.
Hello everybody, my name's Lindsay Mutavivari. I'm the new head of nursing for neurosciences, and I'm presenting the draft of our newspaper on behalf of the neuro team. So what we realised is that I'd probably already taken some of the learning from the CSUs in cohort 1 when I joined the CSU here, and I already implemented with our complaints handler in the CSU a weekly meeting, which I know is one of the scale up and spread actions from cohort 1. What we hadn't considered at that time, though, is introducing or inviting our complaints handlers from Christina's team. So we have now already implemented that in the CSU, and those meetings are happening every Tuesday. So we're hoping that that will help with our lead time. We've got a display board on the management corridor, which is where all of our complaints handlers in the CSU sit. So anyone that's leading on a complaint will be able to see which complaint they're responsible for, and how we're doing in relation to our response times. We're going to start calling all complainants or relatives of people that have sent in a letter to us. That currently doesn't happen in Neurosciences CSU, but we've committed to, where we are the lead CSU for a complaint, to call in those people within 48 hours or 2 working days, so that we can just introduce ourselves as the person leading on the complaint. There's a recognition that we've received it, and that we will give them our telephone number so that they can contact us if they've got any further questions or they want to chase up where we're up to. What we want to do as a CSU is look at our single response lead time as well as our multi-response lead time, so that we just want to split that data out so that we can absolutely see that the complaints or the waste, if you like, in relation to what we can control as a CSU, that we're absolutely pulling that out and getting rid of that at the earliest opportunity. We want to start measuring our QA time. So I'm new to the QA process as a head of nursing. Steve, our clinical director, QAs a lot of complaints, as well as does Rob Rathbone, our general manager. But we just want to make sure that we're not wasting any time with our QA within the CSU. So when a complaint comes to us, that we're really clear that we're getting that back to the complaints team as quickly as we can. We want to explore implementing a clinical lead or a consultant lead for quality in the CSU, and Steve's looking at that in relation to see whether anybody's interested in taking on that responsibility. We want to look at our internal targets and make sure that our CSU are fully cited on what our internal targets are for getting responses back to us as a tri-team for QA. And we want to look at some coaching for some of our newer colleagues that may not have been as familiar with how to write a complaint response. That's it from Neurosciences. Thank you.
Brilliant. Next slide, please.
So hello, my name's Sarah Miller. I'm Head of Nursing for Cardiorespiratory CSU. We are very much mirroring quite a lot of actually what Lindsay's just presented. As a CSU, when we looked at our TPR chart and our lead time, the one area that I've been concerned about for quite a while is the potential amount of waste that we've got in our system and the number of defects and rework that we certainly have been doing around our internal complaints process and with our complaints team's colleagues. So what we've done, we've reviewed our CSU standard work. There was a flowchart that had been designed by the CSU some time ago, and actually within that flowchart it included the what ifs, as in if there is a defect or reworks required. And for me, it's around streamlining all of that out, because actually our standard work should be our perfect process, and this is absolutely what we're striving to deliver. Within that, the response times were not clear, and very much as what Lindsay has articulated, we are introducing an investigation lead phone call. Granted, that may well be the head of nursing or whoever is leading on that complaint, and they will phone the complainant within 48 hours to ensure that actually we fully understand what their concerns are. We go through the questions to make sure that we are answering exactly what the complainant wants, and whether or not there'll be opportunity to answer something there and then and potentially close some aspects down to really personalise the complaints process for our complainants. So we've also looked at our internal response times, and for a 20-day target complaint, we've basically quartered the process up. So 5 days for comments, 5 days for writing, 5 days for Q&A, and then 5 days to go to the exec team. This is all in draft at the moment, and it's gone out to our CSU and our complaints handler for comments. So that's been devised and we've reworked in the last week. We're also going to widen the CSU leads for complaints across the CSU. It's very nurse-centric at the moment, and that's something the coaching model will be very beneficial to us as a CSU. So we're going to take up that opportunity. Again, we are having a weekly huddle. It made me smile, Lindsay. Ours is also on a Tuesday. We started that process last week with the visual management, and obviously we're a cross-site CSU, so through our daily operational huddle, it's been extended on a Tuesday to cover our complaints process, and our complaints handler is coming to that as well. For me, a big element is around sharing that learning and having the assurance in place that actually what we say we're going to do, we have done, and as a CSU, we're fully assured of that. So in relation to Datix, I think we can strengthen how we use Datix. So when we promise our complainants that an action may well not have yet been completed, but it will be, whoever's leading for that complaint, that is assigned on Datix, and then they close that loop. We have got good assurance processes through our governance structure, but it is just strengthening that. So yeah, we're so excited to be part of this. It's really timely for us as a CSU, because we know that we've got some improvements to make. So I want to really thank Christina and the team.
Thank you, Sarah. Could we move the slide on a couple of slides? We've actually got that wrong, I'm afraid. Sorry, Sarah, you didn't have your slides to work to. Could we move them on to women's, please? And the next one, thank you. That's wonderful. I'll invite Eleanor to speak to this. Thank you.
Hi, thank you, Christina. I'm Eleanor Gleed, and I'm not a head of nursing. I'm actually specialist midwife or nurse, depending on which subspeciality I'm dealing with for Women's Clinical Services Unit. And I actually initially deal with all the complaints that come into our CSU, whether that's nursing, medical, gynae, obstetrics or Leeds fertility. Again, very excited to be involved with this work. It's some of the things that we're suggesting and that we're taking forward are things that I've wanted to do for some time since I came into this post 2 years ago. With particularly, I think Tuesday is obviously going to be a very busy day for everybody because we too are going to have a huddle on a Tuesday. Up until this time, I had a meeting every other week with our complaints handler, but we'll take that was on a Thursday, but we'll take that forward now to be a huddle with the triumvirate and anybody, other interested parties that want to join us. We already have a kind of a production board in our PA's office, but obviously that does need some development to include all the details that we need to discuss in that huddle. And obviously we'll invite in Laura Proctor, who's our complaints handler, will be joining those meetings. Particularly interested, something I've wanted to do for a long time and that we've already discussed, I will take forward all new complaints that come into our CSU now. I will contact that complainant personally within 48 hours of it being received. I am part-time, but hopefully I can achieve that. Just mainly to discuss, again, like everybody else has said, get a proper idea of the questions that complainant wants answered, so that we make sure that we're being as succinct actually in answering everything that they need, because we too have a lot of defects, spend an awful lot of time, especially our maternity complaints. Some of them have been 20 pages long and yet they still come back as a reopened because we've not answered everything they wanted. And certainly from a written complaint, we don't get the full idea of exactly what that patient's asking. So, and also taking on from that, I'm very keen to address complaints through a meeting rather than a written response. I have, over the last 2 years, realised that from the meetings I've done, where obviously not face-to-face at the moment, but through the media, they don't tend to come back as a reopen because we can answer all the questions in that meeting, even if there are questions that weren't on the original complaint. And I can also then agree that any actions that we take forward from that meeting, I will then feed back to that complainant at a later stage to tell them the actions have been completed and what the outcome's been from that. With take from actions point of view, yeah, we will be we're looking forward to having that possibility to record on Datix. We do have an actions complaint pro forma at the moment. I'll hand on heart, I've maybe not been as good at filling those in as I should have been, and I think making it a formal process like on Datix will encourage that. I can't think what we have on our next slide, please. Could it just move on to the next slide of our... I know we discussed in the meeting last week about the complaints packs being changed. I know John's dealing with that, just because when I started doing this job, I was very much focused on using the complaint pack and answering the questions as they came up in the complaint pack. I very quickly realised that actually that's not the best way forward, and got into the habit then of creating my own list of questions. Again, that will be improved by actually speaking to the patient. I think that's it. Have I missed anything off there? I don't think so.
Thanks so much. Next slide, please, if we've got that available. Thank you. So finally, just from a complaints team perspective, we will be, of course, supporting the CSUs in all their endeavours, and specifically making sure that we enable complaint handlers to be present as we want them to be in the CSU weekly meetings, setting up our weekly meetings with the CSU so that we've got a way of driving this process forward and working together, leading the development of the model of support for complaint writers. And you've heard from a couple of CSUs how important they think that is in all of this process. Changing our complaint packs to encourage phone calls to a complainant as soon as complaints reach the CSU. We identified there was an error in our complaint packs through talking to the CSUs during the workshop, and we need to fix that quickly. We're also going to be doing some work around datics, adding some fields in that help us capture information about when those calls to complainants have been made by CSUs. And also we'd like to work with our CSUs this time on working up the best model for ensuring that we can capture actions that arise for complaints in datics, and clearly it would help to have their involvement with that. And finally, we will be supporting the work that Lindsay talked about in relation to trying to improve medical engagement in complaints and trying to understand how best to support that. Next slide, please. Wonderful. So next steps are to come back and talk to you again on day 30, when we will be starting to see how the data is shifting, hopefully in relation to the work that we're doing, and always through this forum sharing our learning. So many thanks. That is all we have to report out today, and thank you for listening.
Well, thanks Christina and Sarah, Lindsay and Eleanor. I think that's fantastic. I think this opportunity of the scale up and spread is absolutely vital. It's all well and good doing a project in one area and seeing the benefits that brings, but to spread that across more of the hospital just adds, more and more value as we go. So I'm conscious we're kind of out of time. If anybody's got a question just to follow up, probably just take one question, or we could just say thank you and see you all next week. I think it's thank you and see you all next week. Thank you, everybody. Take care.
Thank you.
Thank you.
Thank you.
Bye.